Hi everybody, we're going to wrap up this course with special senses. We'll talk about the eye and the ear. In your course pack, the eye information begins on page 127. It's interesting to note that we know how much the brain is involved in vision processing. In fact, we know the occipital lobe is the point where the vision reaches your brain and where processing or association occurs. So your brain can operate with so few clues that you probably can see a dog in this picture leaning down and sniffing the ground and the shadow of a tree in the background. We'll talk more in this chapter about how the brain and the eye and the brain and the ear integrate together. Let's start by talking about external eye structures. The external eye structures include the eyelids, which protect the conjunctiva or moist mucous membrane from damage. There are tarsal glands between the eyelashes on the eyelids. If you've ever woken up in the morning with crusty sleep in your eye, you've experienced excess secretions from those tarsal glands between those eyelashes. Normally, those tarsal gland secretions are meant to keep your eyelids from sticking together. Recall that orbicularis oculi is the muscle that helps to open and close your eye. The conjunctiva is a moist mucous membrane that covers the inner surface of your eyelids and the surface of your eye. If you have inflammation of the conjunctiva, we call that conjunctivitis or pink eye. And that can come from anything ranging from a virus, bacterial infection, dust or smoke, or even just wind blowing in your eye on a really dry day. The lacrimal gland is found on the lateral side of the eye. Keep that in mind, L for L, lacrimal on the lateral side. The lacrimal glands produce tears. Those tears are meant to moisten the eye and wash anything that may be in the eye toward the medial side. You'll notice on the medial side of the eye there are canals here. These canals connect to your eye and carry those tears down into the sinuses. That's why it's important to not touch your eye with dirty hands, or even hands that you know are not clean. Anything on your hands can be transferred to your eye, which then can be transferred into your sinuses and nose, which then can travel down into your throat and beyond. So you'll notice here in this picture the lacrimal gland on the lateral side of the eye and the tear ducts or canals on the medial side of the eye. There are 6 extrinsic muscles, meaning they're on the outside surface of the eye. There are 4 rectus muscles, meaning that they are straight muscles. And there are 4 oblique muscles, meaning that they're somewhat angled at a curve or in a diagonal position. These rectus muscles help position your eye up, down, left, and right, while those oblique muscles will help to fine-tune what you're looking at. So these 6 muscles are, of course, voluntarily controlled skeletal muscle. Let's talk about the 3 layers of the eye, as if we were to cut into the eye and look at it in cross-section. There are the fibrous tunic, avascular tunic, and neural tunic. Tunic simply means the layer of the eye. So that takes us now to the top of page 128. We'll now talk about the fibrous tunic first. The fibrous tunic has 2 components, the sclera and the cornea. The sclera is the tough outer portion of your eye, sometimes known as the white of the eye. It is composed of dense fibrous connective tissue embedded with tough collagen fibers and stretchy elastic fibers. There are blood vessels and nerves in the sclera. The sclera, in fact, is the point of insertion for those extrinsic eye muscles. Now the cornea, you can see, is a clear portion of the eye. It covers over the iris and pupil. So there are no blood vessels found here because that would block your view. The cornea makes an interesting case. Because it lacks blood vessels, it can be transplanted without rejection. Here you can see the white of the eye, or sclera. You can see blood vessels embedded in that sclera. The cornea is a transparent portion that lacks those blood vessels. Here you can see a picture of the cornea shape from the side view. If a misshapen cornea is in place, then we call that astigmatic or an astigmatism. That unfortunately creates multiple focal points on the retina of the eye, which means that you may have blurred vision, and you may not even be aware that you have blurred vision. You may simply have headaches from what you're trying to look at. Both glasses and contact lens can correct an astigmatic cornea. A normal cornea should make one focal point on the retina, not multiple focal points. Let's talk about the vascular tunic next. It's composed of three parts: the iris, ciliary body, and choroid. Now the iris is the colorful portion of your eye that controls the amount of light that reaches the back part of your eye, known as the retina. The color of the iris is based on the amount of pigmentation deposited there. Melanin, the same pigment that gives coloration to our hair and skin, also gives color to our iris. The darker the iris, the more protection we have in the retina against UV radiation and damage. The lighter color of the iris means there's less pigmentation deposited there. We know the pupil inside the iris is the opening into the eye that allows for light to pass through back into the retina. The size of the iris is regulated by smooth muscles, and of course in a dark condition, we see the example on the right, when there's low light levels, that pupil will dilate. However, when you're in bright light conditions, that pupil constricts. You can see here the iris, the lens, which is actually not labeled, let's go ahead and put a name on it there, and the ciliary bodies holding on to that lens. If you think about the way a trampoline works, a trampoline has these wires that connect it to a frame. If you bounce on the trampoline, those wires should keep that trampoline in place. The last thing you want is for that trampoline to fall through when those wires break. So the ciliary bodies you might think of as the wires that connect the trampoline to the frame. When your lens changes shape, as it does to refract light, those ciliary bodies anchor that lens to the rest of the eye wall. So the choroid is the third portion of our vascular tunic. Vascular means it is a blood vessel rich layer. In fact, that is what the choroid is. If you look around the outer portion of the eye here, you'll notice the sclera is the outermost layer. Come in a layer is the choroid. It's a blood vessel rich layer that nourishes the retina, and then the retina is the innermost of the three layers. So if I numbered these from outermost to innermost, I would go sclera, choroid, and then finally that retina. So our third tunic is called the neural tunic, and it includes the retina. The retina is the most important layer here because that's where we include photoreceptor cells. Now, there's two portions of the retina. There is a pigmented layer that captures the light and prevents it from being scattered back out of your eye. And there's also a neural layer. That neural layer includes photoreceptor cells like rods and cones. Those rods and cones are important for helping to relay that visual information back into your optic nerve. What you're looking at here is a picture of the retina. You'll notice the optic nerve looks like it's glowing yellow in this picture here, and the fovea is sitting over here. Okay, so I want to talk about the fovea for just a moment. The fovea is called the fovea centralis. That is the highest concentration of photoreceptor cells, known as cones, in the eye. When you look directly at something, that's where the fovea centralis is receiving the information. It's what you're looking directly at. The fovea centralis is actually sitting in the center of a macula lutea. That is a yellow spot in the back of the eye. So if I were to draw that fovea right there, then the surrounding portion is called the macula. Okay, so in the retina, there are two layers. There's a pigmented layer and there's a neural layer. It is in the neural layer that we're looking for the fovea centralis to be centered in the middle of a macula lutea or lutea. That's a yellow spot. So that's our vision that's the sharpest. If you've ever heard of macular degeneration, then vision becomes less clear and sharp because of degeneration of that portion of the retina. So let's talk about the retina for just a moment and rods and cones. Rods and cones are photoreceptor cells. It is their job to detect either bright light images or dark, low light level images. So the rods and cones that you can see pictured here have somewhat of a different shape. There are different things that stimulate each of these. Bright light conditions will stimulate a cone, while low light levels will stimulate those rods. We have more cones in the fovea centralis than we do rods. Rods actually surround that area. Now, on the bottom of page 128, you'll notice something called a blind spot or optic disc. Inside the optic nerve, there's actually an area where there are no rods or cones. So that means that there's an area where we cannot process vision. You probably never notice this if you have both eyes open all the time, because our eye fields overlap each other, so you never get a sense that there's anything missing from your visual field. But if you had to operate with simply one eye, you would realize that there was parts of your vision field that might be missing. Rods are actually one of our two types of photoreceptor cells. They work best under low-level conditions of light. In fact, these are our night vision types of photoreceptor cells. If you happen to stay in a dark environment for a while, let your eyes adjust, you can see better because your rods are better able to process those lower levels of light. The rods that you have in your eye are not necessarily in that fovea centralis, but rather along the periphery of your eye. These photoreceptor cells help you to see images at night, shapes and outlines, and movement at night. These are not your color vision cells. Now, if you happen to have poor night vision, it may be one of two things. Sometimes people are myopic or nearsighted and unable to see well at night. That may simply be the reason for underlying poor night condition vision. Otherwise, people may have a true vitamin A deficiency that results in night blindness. If you happen to have a true vitamin A deficiency, it is rare because we normally store that vitamin in our fatty tissues. But if you do have a vitamin A deficiency, it can cause night blindness. You can see here that we have rods and cones. The rods are, of course, the marks here. There's several of these that are rods. And then the colorful ones are considered cones. Cones respond to bright light conditions, while rods respond to low light conditions. Now, those cones are actually our colorful light detectors, and they work best in bright light conditions. You probably realize that when the sun is up, you can see colors very easily, but as the sun starts to set, it becomes very difficult to distinguish among colors. We know that cones are responsible for color vision. If you have true color blindness, then you may be unable to see some of these numbers here. There are more types of color blindness than just simply red-green color blindness. There's even blue and yellow color blindness. So some of these numbers may pop out at you more than others. And if you have a true version of color blindness, you may have a difficult time or impossible time seeing any of these. So from the top left, you have a 58, top right an 18, bottom left is an L in one color and an E in another color, and bottom right is a 17. Here's another set of color blindness tests. If there is a genetic condition that underlies your color blindness, then you may be unable to distinguish among certain colors. Like I mentioned, red-green color blindness is the most common form, but there's also other forms. Top left is 25. Going down, there's 45 and then 6. Top right is 29. Going down that column, there's 56 and 8. So what is projected on your retina is in fact upside down or inverted and reversed. Very early on, when you have vision, your brain learns to flip that image right side up. So that's why it's critical for babies to be able to see from the point of birth onward. If they don't see, then their brain has a difficult time processing images that it sees. So let's talk about the cavities of the eye. There's an anterior cavity and a posterior cavity. The anterior and posterior cavities are divided here by the lens. So that is the dividing point between the front and the back portions of the eye. Each of these cavities contains a semi-fluid medium known as a humor. The aqueous humor is found here in the anterior cavity, while the vitreous humor is found in the posterior cavity. So these humors allow to further refract the light or bend the light as it travels through the eye on its way back here to the retina. Since we're talking about the retina, this fovea back here, this central focal point, is actually where we want that light to focus. Now, the anterior cavity can be further subdivided into two chambers, an anterior chamber and a posterior chamber. The dividing point here is the iris. So what is behind the posterior chamber is between the iris and the lens, while what is in front of the iris is in the anterior chamber. Now, if you've ever had a glaucoma test done at the eye doctor, they may have pushed a machine up against the cornea here to detect the pressure. If there's high pressure here, that can cause damage to the cornea and cause blindness. So it's important to know that the fluid in that anterior chamber is properly draining through tiny canals in order to relieve and alleviate pressure on that cornea. So we know the lens is a refractory part of your eye. In other words, it bends light that comes through and focuses that light back here on the retina. If you've ever held a magnifying glass over the grass in the summertime, you know that light focuses on a certain point and can heat that point up. That is the same concept with the lens. The lens refracts or bends light onto the retina. The goal is to send that light to a focal point at the back of your eye. It's called the fovea centralis, and it sits right in the middle of that macula at the back part of your retina. If the lens becomes cloudy, which happens with age or with exposure to smoking or even electrical currents, then the lens can become cloudy, and it appears like you see here. Nowadays, we have an easy way to replace the lens and allow a person to be able to see clearly. So let's talk about the pathway of vision. It's found on the bottom of page 129 of your course pack. When light strikes your cornea, it travels first through the anterior cavity and the aqueous humor found there. It travels through an opening in your iris known as the pupil, and then light is now bent or refracted by your lens. That light now travels through the vitreous humor on its way through the posterior cavity to the back part of your retina. Ultimately, it's going to arrive back here at a focal point. That focal point, or fovea centralis, will send that information over to the optic nerve. The optic nerve, by the way, has a blind spot where there are no rods or cones. You don't ever notice this if you have two functional eyes. Let's now switch pictures and talk about the pathway of this information back into your brain. So when each eye receives visual information in the retina, it is then transferred to the optic nerve. The optic nerve exits out the back side of each eye. The optic nerve crosses here at the optic chiasma. That's kind of this X shape right here. You'll notice that vision from each eye travels back on the opposite side of the brain as well as on the same side of the brain. And of course, we travel through the thalamus, which is our routing station for pretty much everything. I just put a note here that this is in the thalamus here. Okay. And then, of course, that information travels by association fibers all the way to the back of your brain and arrives at the occipital lobe. So occipital lobe is where we house both the primary visual cortex and the association. So that's where we not only receive vision, but we also make sense of and integrate what we see. Here again, you can see that pathway from optic nerve to optic chiasma. This lateral geniculate nucleus, that's the thalamus. We just simply call it that. Keep things simple, right? Okay, travel down association fibers, which is called optic radiation here. And we're heading back to the occipital lobe. That's where we have visual reception and processing. Just a couple of things on the last page there, that's 130. We already talked about the refraction of light on the retina. Let's just now mention that there's a couple of disorders here to focus on. There are a couple of issues with eyeball length. If you have a short eyeball or a long eyeball, that causes problems for the way the light focuses on the retina. If you're myopic, that means that your eyeball is too long and you are nearsighted, meaning you can better see up close than you can far away. Corrective lens can help with this, or contacts can help refocus that focal point on the correct portion of your eye. Hyperopia is farsightedness. That means the eyeball's too short for the proper focus. And again, you have better distance vision than you do up close vision. So again, lens such as contacts or glasses can help correct the focal point and allow you to see properly. Everybody's headed in this direction. By the time you reach your 40s, you're going to have what's called old eyes. These are presbyopia. The eyeball does shrink with age, so the eye, it, of course, is unable to see all the ranges from up close to far away like it once was. The lens also becomes less flexible with age. So if you never wore glasses any time in your life, you may pick up a pair of reading glasses in your 40s. If you already wear glasses, you may then pick up a pair of bifocals or trifocals in your 40s. All of that has to do with the way the eyeball changes shape and the lens becomes less flexible with age.